everyone. I want to start on time so that all of our speakers have the opportunity to get there full time. We're down the home stretch. I don't want to say we've saved the best for last, but we've saved the best for last. The first talk is, as you see up there, the status of seasonal influenza vaccination in Latin America and the Caribbean, lessons learned from the H1N1 influenza pandemic, vaccination that could be applied to COVID-19 vaccinations. And Alba Maria Ropero from PAHO will be speaking now. Alba Maria is a senior epidemiologist and regional advisor on influenza at PAHO. Her work focuses on the development and implementation of regional and worldwide immunization program policies and strategies and emergency outbreak response. And I just want to say that we could not have had this successful meeting without the support and input of Alba Maria and the team from PAHO, but especially Alba Maria. Thank you so much.
Thanks.
And we're all interested in it and want to hear your talk.
Thank you, Dr. Berman. It's a pleasure to share with you this PAHO's experience on influenza vaccination in the Americas. For this, I will cover these topics. I will talk about influenza pre-pandemic, influenza in the context of the COVID pandemic, and also some lessons learned from H1N1 and some key messages. In addition to the global influenza strategy that was presented by Dr. Vicari the second day of this meeting, we had another framework, which is the Influenza Immunization Agenda 2030. In this strategy, we have disease goals such as elimination or eradication of diseases, and we have also reduction of influenza disease burden in a global level. And also in PAHO region, we have our regional immunization action plan, which includes influenza as well. Regarding the influenza vaccine recommendations, we have, since 2004, we have recommendations for influenza vaccination in the Americas made by our technical advisory group on vaccine preventable diseases. They encourage countries to strengthen their surveillance systems in order to know the influenza disease burden, in order to conduct cost-effectiveness studies of influenza for vaccine influenza introduction, and also to understand better the seasonality of influenza in tropical countries in order to see when is the best moment to vaccinate in these countries and with which formulation. They also recommended the vaccination of high-risk groups such as children, pregnant women, individuals with chronic diseases, the elderly, and healthcare workers. In 2012, WHO, through the SAGE, which is a Global Strategic Advisory Group on Vaccine Preventable Diseases, they updated the position paper and recommended to identify the high-risk groups and gave the highest priority to pregnant women. If a country had to introduce a vaccine and starting with a group, they recommended at least to start with this group because it was a high-risk group, highest risk group. In this map, you can see all countries using or having national influenza vaccination policies in all WHO regions. And you see the green map, and most countries in Latin America have introduced the vaccine. In this table, we have a summary of countries vaccinating different high-risk groups. We have 39 countries out 51 countries and territories. We include here French territories, Dutch territories, all the countries and territories in the region. If we have 39 countries with vaccination policies, countries and territories, sorry, 39 of them have policy for healthcare workers, 37 have policy for people with chronic diseases, 34 have policy for the elderly, 33 have policy for pregnant women, and 30 for children. I would like to highlight here pregnant women. Before the pandemic, we only had 7 countries with vaccination policies. And after H1N1 pandemic, we have now 33 countries. This is a huge increase in vaccination in pregnant women as a result of the learning from H1N1, because it was one of the highest risk groups during the pandemic. In this map, you see the formulation used by countries. In blue, you have the Northern Hemisphere formulation, and in purple, you have the Southern Hemisphere formulation. And I would like to call your attention here to Central America, for example. They used to have a mix of formulations used in Central America, and now most of them have switched, you see, switched from Northern to Southern Hemisphere formulation, and Colombia as well. And then this was based on better results from the surveillance systems in countries, strengthening the surveillance. They know better now how to know the seasonality of the influenza, and also disease burden studies that they had in place. And then countries have been switching this formulation based on evidence more properly to their seasonality. And this is important for you to know that this is a result of a very good surveillance and also participation of NITAC supporting them in this changing in these policies. This is only an example that I want to highlight here in this regard. For example, El Salvador used to have Northern Hemisphere formulation, and you see here the big peak, and they vaccinated after the peak. Now with this analysis and this switch, they are vaccinating with the Southern Hemisphere formulation before the main peak. And this is part of the results of this analysis. And our TAC addressed this issue in 2015 and gave recommendations to tropical countries in order to analyze in detail this information and adjust vaccination policies. Now, vaccination coverage. You have here 30 countries with vaccination policy in children, and we have only, in PAHO, we have data from 20 countries. Not all of them are reporting to countries. And also for elderly, we have 33 countries, and they reported, 19 countries are reporting coverage. The vaccination coverage is in some countries is very good, but not in all of them. There is a lot of room to improve here in vaccination coverage in different groups. As we have been discussing that we need to improve the performance of the immunization programs. In pregnant women, vaccination in pregnant women is important that highlight here that they have better vaccination coverage, but as well, we don't have all countries reporting the vaccination coverage. And then we need to understand what are the barriers to these vaccines, to the uptake of these groups. And vaccination and healthcare workers, I would say that they have better coverage. In most countries, they are doing better in the uptake of the influenza vaccine. Now, we mentioned, we have heard about the vaccine effectiveness in developed countries, in the United States and Australia, for example. But now we have vaccine effectiveness data in the region. And this was because there was a network created in PAHO region in order to estimate vaccine effectiveness against hospitalization among children and elderly. And this was based on the SARI network that Andrea presented the second day. We had a pilot, we had an implementation process, and we have some results that I want to share with you. In addition to BE, these countries also have contributed with other evidence for influenza in general. And then we have here some results published. We have the BE in ill children is around 47, 50. This is similar to the ones that you have here in the United States and in other countries, and for the elderly as well. And we have been publishing this and supporting countries. This is the first time that we have a network in low and middle income countries. This is the result of the collaboration with the influenza team and immunization and laboratory people in countries in order to have these results. Now, other evidence that the country have producing, there are different studies that we have been conducting. here in your right, you have a small picture of the article in Nicaragua. This was started with Joe Brissy and PV in order to improve the vaccination coverage in pregnant women. And we have been also conducting studies in order to understand the enablers and barriers in maternal immunization, and also healthcare workers in some countries in the region, in collaboration also with Yale and Yale University. Now, vaccination in context of pandemic. Meanwhile, we started the pandemic. So countries in the Southern Cone had, they were getting ready to enter to the seasonal influenza season in the Southern Cone. And then we were in the middle of these restrictions and lockdowns, and PAHO had to recommend countries in the middle of this situation. We didn't want to have two epidemics at the same time. And then we, with the collaboration of TAC, we made these recommendations that you see here in your right, that those were made in March 26th. And then the recommendation was for, especially for countries in the Southern Cone, to prioritize the vaccination of high-risk groups against influenza, even though many of these health centers were closed or they had these restrictions. We invited them to develop some strategies, different strategies to reach these groups. Because the idea was, because the main objective, of course, it was to prevent the disease burden, but also to reduce the burden of the health services with influenza case, because they had to be free up for COVID patients. And then we issued these recommendations and promoted the vaccination of healthcare workers, elderly people, and people with chronic diseases and pregnant women. And then 13 countries conducted campaigns and established a goal of 110 million. And I would like to share, to say that this was one of the most fantastic experiences in the middle of the pandemic. Countries were very innovative, using different strategies to reach groups, high-risk groups, and also protecting the healthcare workers with the PPE, because we didn't want them to be infected. And then they have different approaches. For example, they had phased approach for high-risk groups. For example, Brazil established the first 2 weeks of the campaign was for elderly, and they installed vaccination posts in empty schools, and they vaccinated the elderly in empty schools. They didn't have to go to the hospital or to the health centers. Others had vaccination in mobile teams, or drive-through vaccination, or vaccination by appointment. And you see many pictures. That was fantastic. There are many experiences in this. And that was also in the framework of the Vaccination Week of the Americas. This is the result. We had 100 million people vaccinated. We had adults, more than 33 million vaccinated. And this was in less than 2 months. And also healthcare workers, people with chronic diseases, and other groups. They have to establish a very good communication to inform that it's not because vaccinating against flu was protected against COVID, but the idea to avoid the co-infection and also to prevent the disease burden. And Martin mentioned yesterday as well that there was an interim recommendation from WHO, and then this was issued in 21st of September. And that was for highest risk. They highlighted the importance of vaccinating healthcare workers and older adults. And of course, maintaining the additional groups, but the priority was for these 2 groups. And there is some evidence also that suggests that vaccinating against flu could impact the mortality in the elderly. That is important to document as well. Now, some lessons learned from H1N1. I would like to say that we documented in different publications the experience in PAHO, including vaccine adverse events, including challenges in different components of the campaign. But I would like to highlight here something. In this graph, countries which already had influenza vaccination, seasonal influenza vaccination, were able to vaccinate quicker or quickly at that time against H1N1 because they have the infrastructure. They knew how to reach not the elderly, to reach the people with chronic diseases, to reach healthcare workers. And then that was important to have. It's important to have this kind of infrastructure. We are building on that, and that will be similar for COVID-19. Results in general, there was a very good uptake of the vaccine based on the goals, but some countries had very good performance, others not. But this was affected mainly because we had a very bad press and misinformation and rumors and many other things that were circulating at that time. But one of the other challenges that we had was the data quality, because how to estimate the denominator, for example, for people with chronic diseases or vaccination, establishing goals for healthcare workers. They established a goal of the first responders first, and then when vaccine became more available, they opened to every groups or other groups, and then we had a mix of vaccination of other people other than high-risk groups or target groups. That is important, and we are taking into consideration all of these lessons. And the communication part that was critical because of rumors, and then the issue to train Minister of Health people, spokespersons, that was important. And then we are using these lessons learned, and now in planning for COVID vaccination, we are reviewing these lessons. We have recommendations, guidelines that we are working on right now for COVID vaccine planning at least. And we have been focusing in 4 key components: cold chain, information system, vaccine safety, and communication. Sorry, I had here, it's a bit twice. But this is the main focus, and countries are working on that. They are developing the plans because they have the opportunity now to prepare for COVID vaccine, and they have to know what is the cold chain capacity and prepare the systems, and that they are working on that already. As key messages, I would say that influenza is a priority in the context of pandemic to decrease annual mortality and also to reduce the burden, additional burden to health systems. Innovative vaccine delivery strategies are key to reach high-risk groups, particularly the elderly and people with chronic diseases, and that will be important for COVID. And there is a need to continue strengthening surveillance, monitoring coverage and BE, and ensuring that we are using this data to adjust our policies and strategies. And now, as I just mentioned, to leverage on lessons learned from H1 and seasonal influenza will be very important for us to go ahead with the planning for COVID vaccine, given the similarities and the infrastructure that we can use for COVID vaccination. Thank you so much. That is my presentation.
Thank you so much, Alba Maria. I think we have time for, we have 2 minutes, time for some questions. I can't, because the slides are up, see everyone. So if you have a question, please just ask your question. Don't wait for me to recognize you. Oh, there we go. Okay, let me see. There's one chat. Alba Maria, thank you for your excellent work and presentation.
Thank you.
And as I said, well, if the presenters give their permission, we're happy to make the presentations available after the meeting. So I would like now to introduce our second talk. Pablo Bonvehi is the head of Infectious Disease Unit and Infection Control Section at the CEMIC University Hospital. He is a specialist in internal medicine and infectious disease, epidemiology, and public health, a former president of the Infectious Disease Society of Argentina, and is a member of the National Committee on Immunizations. And Pablo's going to talk about country experience in overcoming barriers to seasonal influenza vaccination. Thank you. Have we figured out how to get the screen on for Pablo? There we are.
Yeah. Okay. Thank you, Dr. Berman and Dr. Andrews for the invitation. The title of my presentation is Overcoming Barriers to Seasonal Influenza Vaccination in Argentina. This is my conflict of interest. And in the agenda, I will go to explain the data about vaccines and influenza vaccination in Argentina, the impact of the 2009 pandemic in our country and on influenza vaccination. I will show you some data regarding effectiveness, safety, and coverage rate in Argentina, what happened with COVID-19 and influenza vaccination in my country, and which vaccines we have available in Argentina, and finally, the misconceptions and barriers against influenza vaccination. How can we overcome these barriers? This is our national immunization calendar. That means that these vaccines are free and obligatory for all the groups that these vaccines are addressed. We have almost all vaccines in our national calendar, as you see here. As a brief history of influenza vaccination in Argentina, in the 1990s, the national government developed the first influenza campaign addressed to senior citizens. And other important point of the history of influenza vaccination in my country, it was the 2009 influenza pandemic that generated more awareness among the community, the public health official, regarding the importance of disease and its prevention, improved the lab capacity, and generate an agreement between the government and a local consortium to produce influenza vaccine locally. And as a result of this situation, the influenza vaccine was formally introduced in our national immunization calendar. In the pandemic of 2009, the highest incidence group was children less than 5 years of age, with a rate more than 76 per 100,000 population, followed by the young adult group. And the hospitalization rate due to acute severe respiratory disease was 35 per 100,000 inhabitants. And we identified at least 626 deaths in our country that year. In this slide, you can see what happened with our lab capacity. In the left side, you see in 1997, in the main lab, our reference lab in Buenos Aires city, and we have some labs in some provinces with capacity to perform influenza detection by immunofluorescence. In 2008, we improved the lab capacity, but the main point for improvement in our capacity and resources for laboratory detection of influenza, improving the molecular detection, was after the pandemic. And in 2018, you can see in almost all provinces, we have ability to detect by RT-PCR influenza, and it was also useful for this year for the COVID-19 identification. As I mentioned in the introduction, influenza vaccine production in Argentina was a consequence of the 2009 influenza pandemic. At that year, the project for the installation of an influenza vaccine manufacturing plant was declared of public interest in 4 stages. The first stage was important vaccine supply. The second was labeling and final packaging operation. Stage 3 is formulation and filling operation. And finally, stage 4, that is develop the antigens, that means primary production in Argentina. In 2010, the public BID from the Ministry of Health was awarded to the Synergian Biotech Consortium to produce the vaccine in our country. In 2013 and 2017, the change of technology to produce the vaccine was approved, first based on cell culture and then recombinant technology. It was the situation in 2011. There was an empty field. In 2012, we already have a manufacturing plant in place. And one of the deals between the consortium and the government was to provide influenza vaccines for the national influenza campaigns. As you see here, around 9 to 12 million doses per year were provided for different risk groups. The objective of influenza vaccination in Argentina is not to reduce transmission, it's only to reduce morbidity and mortality. So this is the reason why we don't vaccinate the whole population, that is more than 46 million. The target groups for influenza immunization, that is the vaccine is paid by the government, is those 65 years of age or above, and those less than 2 years of age. All these groups should be vaccinated. We vaccinate pregnant women and women who were not vaccinated during the pregnancy in the first 10 days postpartum, and groups between 2 to 65 years of age who have chronic condition, the chronic condition, pulmonary diseases, cardiovascular diseases, diabetes, and others, and also healthcare workers. In Argentina, we also vaccinate against influenza in the private sector, and the vaccine is available for anyone who wishes to be protected against influenza by paying the vaccine. We have some data about vaccine effectiveness and safety. In the 1990s, we published some data regarding effectiveness to prevent hospitalization in senior citizens, and the data was similar that was already published at that time. And also we have some data regarding the same group, but who have another chronic condition like chronic pulmonary disease. This data was presented in a meeting in 2012 that showed the effectiveness of the vaccine in several years in this age group that also have a chronic pulmonary disease. And also we have data for in the same group for cardiovascular chronic diseases. This data was already presented by Alba, the REVELAC study. And regarding influenza vaccine safety, in general, flu vaccine safety is not an issue in Argentina, although we have some myths that act against the vaccine as in every country. And we published data in the 1990s regarding the safety. After the introduction of adjuvanted vaccine in 2011, we published data regarding the safety of this vaccine in a risk group like the pregnant women. We also perform surveillance, passive surveillance for safety every year by the Ministry of Health. And regarding the coverage rate of the vaccine, we have some data, especially in...
Tenemos datos en algunos grupos de riesgo, como los trabajadores de salud, que fue el más alto, también mujeres embarazadas, y también la cobertura en niños, en niños de la población pediátrica en 2011-2018. En el 2019 nosotros tuvimos muy buena cobertura con los trabajadores de salud, menos en los niños, para la primera y la segunda dosis, y menos para las mujeres embarazadas. Nosotros hemos estado haciendo lo que es la evaluación en el 2013, perdón, y teníamos información sobre la cobertura en nuestra población. Lo que ven aquí, la vacunación de las personas mayores a través de este formulario.
Around 55%, no more than this. And this is a data that we have to have in a better way to measure, because we have different data from different sources. So we need for influenza vaccine coverage to measure influenza vaccine coverage in Argentina, we need better denominator for some risk groups in order to obtain more accurate coverage data, and vaccine coverage rates in some health subsectors, like, as I showed you before, senior citizens, some healthcare service. The private sector, we vaccinate in the private sector, almost 2 million doses each year, but we don't have this data included in the coverage rate. What happened this year with influenza and COVID-19? As Alba mentioned before, we developed a strategy for influenza vaccination in our country. In the first stage, we vaccinate healthcare personnel and senior citizens in March, beginning the 10th of March. In the second stage, we included children and pregnant women, and it was in April. And then in the third stage, we add those between 2 to 64 years of age with risk conditions. Here you see the influenza vaccine coverage rate between 2011 and 2020 between those persons between 2 to 64 years with risk factors and those with 65 years of age or above. And you see how this coverage is not coverage rate, this number of those doses administered. If you see what happened in those with high risk factors between 2 to 64, and you see here is the highest, and these numbers are not complete yet. So it's the highest number of vaccine administered in those years, and the same happened with those elderly, that is the highest number this year, and as I mentioned, this number is not the final number. We need to know which is the final vaccination administration number. And what happened with influenza circulation and COVID-19? This data from my hospital. We have 326 samples this year looking for influenza detection by RT-PCR, and only we have 3 positive cases. That's totally atypical for this year for us. And I asked, and I talked with the head of our national reference lab, and she told me the same, that we have a very low detection this year in Argentina for influenza. And we have data up to this last week of October. And you remember in Argentina, the months for influenza circulation is between April, May to August, September, sometimes to October. But this is the main circulation. And we, in the lab of my hospital, that is a lab with a lot of experience with viral respiratory detection, we performed RT-PCR, and we only found 3 cases between 326 samples. We have another vaccines besides trivalent inactivated vaccine. We have quadrivalent influenza vaccine, but only available in the private sector. We have experience with adjuvanted trivalent influenza vaccine that was included in the national calendar in 2011 to 2014, mostly for elderly. And we have recently published an article regarding the cost effectiveness of introduction of an MF59 adjuvanted trivalent influenza vaccine for all adults in my country. And the conclusion is that this potentially beneficial and cost-effective relative to the currently used TIV through the reduction of disease burden and utilization of healthcare resources. And finally, talking about influenza vaccine myths of misconceptions, which are the barriers? Well, we don't have enough data on vaccine effectiveness and efficacy. I think we need more and better data. We don't have local vaccine production yet because we are not in the stage 4, where the local production of antigen. We are in the stage 3 of the production in the process. We have some myths about influenza vaccination, as in everywhere. We as I mentioned, we have low vaccine coverage for the second dose in pediatric patients, and we need data or lack data that affect the awareness about the importance of influenza vaccination in the community and also among healthcare workers. We need burden of disease studies, impact studies that clearly show the advantage of vaccination, as I mentioned, also denominator for some risk groups and coverage data from some health sectors. Among the community, we see some distrust of the vaccine. It's not everywhere, but we can see this. Fear of vaccine adverse events, ignorance of the objectives and needs of vaccination. As I told you, the objective of influenza vaccination in Argentina is to prevent hospitalization and mortality, not to prevent transmission. Some think about conspiracy theories about flu vaccine, and flu vaccine and other vaccines are not incorporated as preventive strategies like health food, physical activity, mainly in the adult population. Sometimes lack of access is an issue because vaccination centers have a limited schedule of time. Some adults think that vaccines are only for children, and fear of needles, mainly in adults. And among physicians, specialists have limited time to care for patients and many preventive issues to discuss with them. As a clinician, have to take care of many things at the same time in a short time. Blood pressure, cholesterol levels, and also vaccine is another issue that is sometimes not taken into account. Some physicians do not always have sources to obtain secure information, do not see influenza vaccination as effective as other preventive health measures in adults. Sometimes it is an issue too. Some physicians do not have enough knowledge about influenza vaccine immune response, efficacy, and safety. And in the pediatric population, for some pediatricians, they think that there are too many vaccines for children. And how to overcome these barriers? Well, ability to produce vaccine locally is in the way. I hope that we can produce totally the vaccine in the country. And it's education for healthcare professionals and the daily community. Surveillance sites to monitor vaccine effectiveness regularly. We need data regularly about VE, have denominators of some risk groups, better data regarding burden of disease and disease impact, and maximize vaccination centers opening hours during influenza vaccination campaigns. And also we can think about incentive for physicians who prescribe the vaccine. And we need also increase disease surveillance, improve healthcare workers and community education for influenza prevention, maintain and improve vaccine safety surveillance, improve coverage, especially for the pediatric population. And we have some different type of vaccine available that have to see if some of these are better than the trivalent influenza vaccine. And we need, in general, more effective vaccines. In conclusion, Argentina has acquired experience in influenza vaccination since the 1990s. The pandemic influenza H1N1 virus leveraged better lab diagnostic capacity. Local vaccine production is in the last stage for the complete production in Argentina. Effectiveness and safety data are similar to published data. Coverage rate is good in some groups, but we need to improve in the pediatric population, and we need better denominators for some groups. COVID-19 pandemic increased the demand for influenza vaccination. It was a totally atypical year, not only in the viral circulation, but also in the demand for the vaccine at the beginning of the year. We have some alternative for TIV, and many myths and misconceptions about influenza vaccination are ingrained, and we have several alternatives to overcome these barriers. Thank you.
Thank you so much, Pablo. A terrific, excellent presentation. There were two questions.
Steve, you're going in and out. Maybe your microphone, do you have it on?
It's more like an echo.
Yeah.
I think it's poor connection based on my Zoom experience.
He's frozen right now. But maybe I can step in as he reconnects.
You need a pediatrician.
Yeah. Pablo, that was outstanding. Before we go on,
Thank you, John.
a quick question to Alba Maria. One of the major conclusions was that from Argentina, demand went up. Did you see that amongst other countries?
Yeah, I had it in my slide with the results of H1N1. Let me see the data here. The increased demand was 10% up in the southern hemisphere and something like 14 in the northern hemisphere. That was the situation. The issue with influenza is the vaccine is produced and we have to plan the year before because the manufacturers have to produce the vaccine based on country request. And then we couldn't respond to all countries' needs at the last minute. But that was the situation. There was an increase in demand.
So hopefully that will continue to maintain the momentum. Pablo, again, outstanding presentation.
I was dropped off the Zoom call for a minute, but I'm back and I want to introduce Flor Munoz, who's an associate professor of pediatrics and infectious disease at Baylor College of Medicine and director of transplant infectious diseases at Texas Children's Hospital in Houston. She's published extensively on topics related to influenza, RSV, vaccines, and maternal immunization. But we have a special relationship with Flor because we have a site in Guatemala that's a wonderful site for research. Thanks to Flor and her team, we've been collaborating on some very interesting studies. And Flor, I want to personally thank you for your collaboration with the Center for Global Health. It's been terrific. And Flor's going to talk about high risk, including pregnant women versus universal seasonal influenza vaccination, recognizing the impact of COVID-19 on influenza vaccination, as well as all routine vaccinations in children and pregnant women. Thank you, Flor.
Thank you very much. I really appreciate it. And thank you also for the comments regarding our project on Zika, the previous pandemic, the previous big epidemic for sure. So I am going to put this on a presentation mode. I hope you can hear me okay. And this is a big topic, and I hope I'm not going to repeat too much what has already been discussed, but I did want to bring some perspectives regarding, in general, where we are regarding high risk versus universal vaccination, and then talk a little bit about these other aspects regarding coverage and regarding acceptance of vaccine as well. So these will be the topics: high risk versus universal. What are the strategies? High-risk groups of special interest, and we'll talk, I think, mostly about children, because I think for pregnant women, there's pretty good evidence, and I don't need to repeat all of that since Latin America is doing so well with that, but we do need to consider children, and then vaccination during the COVID-19 pandemic. So this is just a quick little history point here. This is influenza immunization recommendations in the United States in the 1960s. And I have there a picture of the different pandemics that we have had since the 1918, where, as we have heard, there was little information about what was really happening there. And it wasn't until after the 1957 pandemic that, these recommendations came along. To basically say that 1960 Surgeon General had a list of who should be given influenza vaccine. And you see from there already the high-risk groups being listed. And the high-risk groups are based on the outcomes of influenza that we measure today, which is influenza-like illness, hospitalization in terms of the severity of illness, and mortality. And these would be the groups that you see there, that some of them continue to be listed, that would contribute to the highest rates of those severe outcomes. And pregnant women are there from the very beginning. Now, I want to point out, because of this recommendation being based on risk and potential benefit of the vaccine, it was not necessarily something that was backed up by clinical studies at the time. So the United States is the only country in the world that has universal vaccine recommendations. supported by all these groups, ACIP, the AP, you know, everyone that's involved in vaccine recommendations, basically saying that everyone starting at 6 months of age should receive their vaccine. And we don't vaccinate under 6 months because we don't have a licensed vaccine for that age group. But the rest of the world, as we have heard, has high-risk group recommendations. So how do we come to this? And again, these are the populations at risk. So we all know them well by now, the young children, the older adults, pregnant women. We have at the center there a list of underlying medical conditions that actually continue to grow. The most recent addition has been actually obesity. And we have included every contact, including family members, but also healthcare personnel, to these high-risk groups, because of the concern that in some of these groups, as we have heard, especially young children and adults, older adults, they might not have a very good response to the vaccine. So we do need to protect them by protecting those around them. When did this happen, this universal vaccine recommendation? It actually happened right after the 2009 pandemic. It had been gradually occurring already in that more groups were being added based on these risk identification factors. But it was really, as I mentioned briefly the other day, after the 2009 influenza AH1N1 pandemic, that it was realized that by the time you count all those people with those conditions, about 85% of the US population was already under recommendation to receive vaccine. And we know that as a strategy, risk-based strategies don't necessarily work all the time, because there's always a possibility that you can miss identifying someone who is at risk. And universal recommendation is usually able to capture everyone without that risk. The only group that had not been included actually was the 18 to 49-year-olds who did not have either an occupational risk factor, excuse me, or they were not pregnant, or they didn't have any health conditions, but they were potentially also, you know, contacts of other people. And the other point that was made is that some adults can have influenza-related complications, even if they don't have previously identified risk factors for influenza, and we know that as well. In addition, as I mentioned there, you can see that there was also concern that with the 2009 influenza pandemic, that virus would continue to circulate and continue to cause disease, especially in younger populations that had not been previously exposed. So there you go. From then on, since 2010, 10 years now, we have a universal recommendation. I want to mention children, and this is just briefly tell you about the evolution, because we know also that children play a very important role in transmission of influenza. They do have the highest attack rates, and they bring flu to their family and to others in the community. This is work from the early 1960s, 1970s, actually, with Dr. Paul Gleason, who started to bring up our attention to children as pivotal vectors. And from then on, we know that children who have some underlying medical conditions will also have high risk. So this figures from CDC, comes out every year, gets updated. I put this one from a couple of years ago, again, to point out that some of these keep changing in order, but we do know that children with chronic lung or heart conditions will have higher risk of hospitalization, which is how we assess for severity of illness. And we've added neurological conditions, children who have trouble with swallowing because they can aspirate and they can have more problems with pneumonia. But what I do like to point out in terms of making a point regarding healthy children is that year by year, almost half of all children who are hospitalized are actually previously healthy. And it's true that many of these are younger than 2 years old, and many times they are admitted for precaution because they have febrile illnesses. Nevertheless, you have a high burden of potential serious illness in otherwise healthy children. And this is, I wanted to start bringing up the issue of COVID, because these are some of the underlying medical conditions that we've described. And I've put in red there those that are common to influenza and COVID-19. And you see how they're eerily similar. What conditions children that have more severe COVID-19 have are basically the same, on the same list as influenza. In addition to that, the picture there to the right is something that happened this year in January in the United States, where it happens every year. And it's, you know, heartbreaking that healthy otherwise well teenagers or other children succumb to the flu, because the flu can do that. And we should not forget that in addition to those with risk factors, any child, any adolescent could be at risk as well, even if they're healthy. So complications, the reason they die or they have to be in the hospital, we've talked about this over time. The fact that flu itself can cause a severe lower respiratory tract infection, that you can have secondary infections. And we didn't talk too much about this, but again, I'm biased by working in a very large hospital with all kinds of complicated patients. And I have seen otherwise healthy children die from influenza, severe myocarditis, and heart failure. I have seen what CNS influenza can do, and other complications that sometimes leave children, if they survive, with long-term sequelae. So it's not to be taken lightly, for sure. Pediatric mortality is the other method of assessing how severe flu can be. And since 2004, pediatric mortality is reportable in the United States. This is after the 2003-2004 season, which was an H3N2 season, where we had clearly a very high number of pediatric deaths. And it was realized that these were not being formally reported, and ever since they are. And although there was a little bit of a lull, if you will, less than 100 deaths reported after that season, after the 2009 pandemic, when we had more than 300 deaths again, it's been consistently between 100 to 200 deaths, more 150 to 200 deaths every year from influenza. And these are the numbers that are just from the most recent CDC flu weekly update, where you see that updated numbers are 194 flu deaths from 2019, 2020, just the previous season. When you look at COVID deaths, there's been also about a little bit over 100, maybe near 200 at this point. And in terms of mortality, it seems that they would have at least a similar impact in children at this point, although that is still to be seen as the pandemic continues with COVID-19. This is what I wanted to show you. If you haven't seen it, thank you, Eduardo, and everyone at CDC for putting these beautiful graphs out. Put things into perspective, right? So we have stopped talking about the flu being worse than COVID when we start seeing really what COVID is able to do. This is our populations, obviously not just pediatrics, but looking at the usual epidemic threshold of pneumonia and influenza mortality, if you will. Now, if you insert there COVID and you see pneumonia, influenza, COVID mortality, it's everything that is in those blue pyramids there, and really leaves influenza very, very low in yellow from every year. So COVID is not flu, and we need to take that into consideration, especially if both are going to be around. Let me then just switch a little bit towards where did we come from, and why do we recommend influenza vaccination in pregnancy? So today, actually, flu vaccination in pregnancy is considered an essential element of prenatal care in the United States, supported by CDC and ACOG and all the other groups that support immunization. If we don't get to vaccinate women during pregnancy, we give them the vaccine postpartum. And this is for any woman who will be pregnant or delivering at the time of influenza circulation. And breastfeeding women can be vaccinated. Again, remember, this was a risk-benefit recommendation since the 1960s, and it has been evolving so that, it was for usually women at risk, very, very little use. I actually did a study in 2003 with one of our local institutions here, which is a big multi-center clinic similar to Kaiser, but here in Houston. The coverage rate was 3% of pregnant women, 3%. That was in 2003. So this is around the time when the recommendations changed so that all women at any trimester should be vaccinated. And even WHO supported influenza maternal immunization around 2005 as well. But it was really, again, the 2009 pandemic that brought this back to the forefront and the attention of everyone regarding how serious influenza can be in pregnancy. Mexico saw some of the first cases. I remember the first pregnant woman during the 2009 pandemic was from Brownsville, very close to where I am here in Texas. And so we really had to pay attention to that. And as Alba Maria has mentioned, this really, really changed the approach everywhere about what pregnant women had as an impact in what that we needed to protect them, leading to the 2012 SAGE recommendation to make pregnant women a priority. Do remember, though, that even with that, we were able to reach about 50% coverage rates after the pandemic, and it's been plateaued since then. I'll give you some updated numbers. And some of the concerns people have had is that even though they're recommended, flu vaccines have not been specifically licensed for pregnant women. And until shortly around before the pandemic, there were not a lot of studies looking at pregnant women safety and efficacy of the vaccination. As of last year, actually, one of the vaccines has been approved in Europe and Australia with an indication specific to pregnancy. It's the only one, and it's based on those clinical trials that happen not in the US, but actually in Africa and Asia, supported by the Bill and Melinda Gates Foundation, that led to obtaining some safety information and efficacy as well. So this is the WHO 2012 position paper. Again, the point of me showing this to you is to say that these recommendations, as you have seen with the PAHO recommendations, are aligned in terms of targeting high-risk groups, healthcare workers, the pregnant women, the younger children, individuals with underlying conditions, and the elderly. Now, for LMIC, it's interesting because they do mention that the high-risk groups there are less well-defined. So these are the traditional high-risk groups. I think it's an important point to make that we do need to learn a little bit more about high risk in LMICs. So pregnant women, again, this graph there is from actually 1918. They do get sicker with influenza at the last part of the pregnancy, especially in the third trimester, when they have physiologic reasons where they have lower pulmonary capacity and definitely complications from influenza. So they have increased risk of severe disease and death. But in that case, flu itself can also cause complications of delivery and to the fetus. So stillbirth, neonatal death, and preterm delivery has been very clearly documented. Pregnant women with underlying conditions would be at greater risk. And there are many, many data that are cited. This is from the WHO paper as to why pregnant women should be vaccinated. In terms of children, again, data from many years ago with that U-shaped curve that you see there, showing that younger children, especially school age and those infants, are going to have hospitalization rates that are similar to adults greater than 50 years of age or older. And that is what puts them at greater risk and why we need to vaccinate. The position paper, as we mentioned before, from WHO, emphasize the need to put pregnant women at the highest priority. And Alba Maria mentioned that. She also showed us some figures. This is just another one that I found to show the progression of how the different countries were implementing the vaccination of influenza if they had it in their schedule. And many of them have, as you can see, especially for high-risk groups, but there's a lot of countries, especially in Africa, that have not. And in terms of the Americas, again, I'm not going to repeat it. Alba Maria showed you the PAHO tag recommendations. So these are aligned, and the 39 countries that have already offering vaccination to pregnant women, which is important. You didn't mention this one, but I like to show it. So this is one of the documents that PAHO put together to help that higher coverage and acceptance of influenza vaccine. And this was complemented as well, as you can see, by a WHO document that I had the pleasure to participate in as well, that gave the different countries the tools on how to implement influenza vaccination in pregnant women, and a specific guidance even for how to assess safety and how to collect safety data. So this is being utilized. Last year I was in Bhutan with the WHO, and we went ahead and used this document to help them as they were implementing vaccination in healthcare workers, pregnant women, and also children. And that was quite ambitious, but it was one of the countries that needed to do that and had the resources. You already also mentioned Alba Maria coverage, so this one is probably not as updated, but making the point that you had made that it's quite variable in Latin America, the coverage in pediatrics and in pregnant women for influenza vaccine, and there's still work to be done. But I do want to tell you that even in the United States, we have work to be done for improving our immunization coverage. So the current Healthy People 2030 objectives are that we should be vaccinating at least 70% of everyone who's recommended to get their flu vaccine, which here it is, again, 6 months and older, everybody should be vaccinated. And even though it's accessible and sometimes totally affordable for people, we still have relatively low vaccination rates. And there are also some disparities that persist, which we are seeing with COVID-19 could be also exacerbated. So this is what we have. So these are the high-risk groups that we've been discussing. This is most updated data. Again, thank you, CDC, for keeping up with this. Some of these are brand new, fresh data that have come up. So in terms of influenza vaccination coverage among healthcare workers, they are probably the best covered. You see that it's about 80% of healthcare providers report that they had received their flu vaccine last year. And obviously there are differences. So the top line there with the boxes in blue are people who work, healthcare providers who work in a hospital. So those are the better vaccinated. The solid line is the average, as you can see. You can reach rates of greater than 90% in some hospitals, but in other clinical settings, especially ambulatory settings and some even healthcare facilities, you might not get to that high level. It's still good. It's still greater than 60%. The strategy here is a mandatory vaccination. So the reason many hospitals reach this high coverage is because they have a requirement that their employees need to be vaccinated. And it's nice to see actually across the board that anybody who has that requirement actually achieves those very high levels. Some within those groups might not, but either, whether they're physicians or other providers, they do in general. Now, what about children? Again, this is brand new data that was just put out, showing us that for children 6 months to 17 years, which is our recommendation here, you see that on average, you see overall is about 63.8%. So about 2/3 of children of that age get their vaccine. But you have a much better coverage rate in the 6 months to 4-year-olds, the younger children, which is wonderful. That's the 75%. So, that still leaves about 1 of every 4 children unprotected, but that is the group at highest risk. And it's really good to see that actually that rate, especially in the younger ones, but overall continues to increase. So we are doing better in the last decade in vaccinating children. And we have achieved, at least for the younger children, that goal of greater than 70%, but we still need to do better. You see the least vaccinated are our adolescents, 13 to 17 years old. And this is just to show a little bit of the disparities. Unfortunately, you do see that Black and Hispanic populations tend to have a little bit lower coverage in general. And where do children get their vaccine? In the United States, it's mostly at their doctor's office. With the COVID pandemic, there has been also an effort to improve vaccination coverage by offering children to get vaccinated in pharmacies or in other settings. But in general, it's mostly at the doctor's office. So that's something to think about in terms of access and being ready for future pandemics. Pregnant women, this is also brand new data. It was just published in an MMWR October 2nd. And you see that for in the last 3 seasons, we do have also improvement. As a matter of fact, I mentioned how in the pandemic of 2009, we had achieved about 50%, which was much better than the national average before that was about 13%. So now we are at about 60% total, a little bit over 60% for last year, which is outstanding. We had never been this high. And we do see, unfortunately, that there are disparities, and the Black population continues to be still behind, a little bit more so than the Hispanic population. But this is really great news, and I'm hoping that we continue to have this higher coverage as we go. Compared to Tdap, for example, which is very interesting, Tdap which is also recommended in pregnancy, as you know, seems to be struggling a little bit. So I thought that it would be the other way around, but it seems like for Tdap, it's a little bit lower right now. So it is interesting whether, I'm not sure if maybe the pandemic had something to do with COVID, that people wanted to get vaccinated. And just like I showed you for children, you see how about still 40% of women remain susceptible when they're pregnant. And women who are offered the vaccine and given the vaccine at the doctor's office, which is usually at their prenatal care clinic, that's where they have the highest coverage. So we do need to keep that in mind, that making it easy and accessible to the pregnant woman is the best strategy possible. We do have disparities that do persist, and we do need to see that you know, when another observation is that when you do have a good, consistent prenatal care, you have a higher likelihood that women will be vaccinated. So overall, it looks like acceptance is better, which is a big change from 20 years ago for sure, and even from a decade ago. This is just to show you from that same publication that, interestingly, there was really not an effect on high-risk conditions. The coverage in all races, but in all women in general, you see with high-risk conditions, 76%, without high-risk conditions, nearly 76% as well. So it doesn't seem to be an issue regarding whether they have high-risk conditions. It's basically based on their pregnancy status. So those are good news. And just 2 points, since we're talking about barriers, when women are asked about why do they want to get the vaccine, this is always the answer, and I get that when I ask women to be in my clinical studies of pregnancy as well, is if it's something good for the baby, if it's going to protect their babies, they will do it. Or if they have a very good, strong recommendation from their providers. And the reasons why women would reject the vaccine would be in general because they have concerns about safety for their baby, not so much for themselves, but for their baby. Or in the case of flu, because they don't really think it works, or they don't really have any concerns about flu because they've never had it. So those are the usual questions and answers that we get. So I do want to say with just one slide, because I could speak for 2 hours about the safety and effectiveness of flu vaccination in pregnant women and in children, but this study, also led by the CDC, the PREVENT study, was done in 4 countries, US, Canada, Australia, and Israel. It's just one of the examples that shows that, first of all, women do have acute respiratory febrile illnesses and they are hospitalized, but we test very little. We don't really look for influenza. So the burden is out there and we are just not necessarily capturing how much there is. Because even though very few were tested, you see about 6% of this population, so about 1,000 out of nearly 20,000 women, more than half of them had a diagnosis of influenza pneumonia when they were tested for it. And you see that comparing those who were vaccinated versus those who were not, the effectiveness of the vaccine was 40% against flu-associated hospitalization during pregnancy. So this is just one example of something recent. We can discuss more later, but flu vaccine works. It prevents severe illness in pregnant women. It prevents the complications of pregnant women who get the flu that we discussed, and it also protects their baby, which is what moms want to know, and we can tell them that now, that they actually do. This is another example of another paper coming from these various flu trials that I mentioned to you that occurred in Africa, that in addition to having improved outcomes, maybe regarding being able to make it to term and having a good sized baby, if you protect the baby against early viral illness with influenza. We've seen this also with RSV, actually, in a maternal trial of RSV. You actually decrease the risk of all-cause pneumonia in those children. And that is critical for especially LMICs. So briefly to mention the last point that I wanted to make is vaccination during the COVID-19 pandemic. All these groups that I have listed there below are in agreement that this year it's more important than ever to get your flu vaccine because we know COVID and flu could be circulating together. I think the situation will be a little different for us in the United States than what was seen in the Southern Hemisphere because you know, people are out and we're on our third wave, and we already are seeing other viruses out there. Actually, I've heard about one case of flu here in Texas already. So we need to be prepared because if we give flu vaccine, that's the point. They're not just decreasing flu illness, but also whatever synergy could exist with COVID, and also decrease the burden on the healthcare system. So SAGE did have a recommendation also that was just published in September, that in the context of the COVID pandemic, the highest risk of groups that are considered priority for flu vaccination are a little bit switched around, with healthcare workers and other adults being listed just because of their higher risk of COVID-19. But the additional risk groups continue to include pregnant women, those with underlying health conditions, and children. And they do make a point that these recommendations are not to supersede, you know, change what was recommended in the 2012 position paper, that pregnant women continue to be prioritized. Okay, so just wanted to bring this to your point. And certainly, just to touch on this, is that the pandemic has disrupted not just influenza, but also routine vaccination. This is data also from CDC, showing that overall, many children, millions of children, 80 million living less than 1 year of age, living in countries that have reported disturbances of their flu vaccination programs, are at risk of having different new outbreaks of vaccine preventable diseases. And this is from the US, how a significant drop in measles vaccination has occurred. And we have really a serious problem because as long as healthcare providers cannot go to work, have not the PPE that's adequate, or families feel comfortable going to get their vaccine, we could have outbreaks of vaccine preventable diseases throughout the world. I will finish by talking about just 2 points here. The COVID vaccines. So we've been working with COVAX on looking at the platforms, the different vaccines that are available. You see they're listed subunit, the vector vaccines, nucleic acid vaccines, thinking about which ones of these vaccines could be suitable for pregnant women. And this is just a timeline to show you where they are. And it's possible that the vaccines that are out there first might not be the best ones for pregnant women. We are still trying to learn about that. But certainly, the discussion about including pregnant women in the vaccination is critical. This is to show you what COVAX is. It's really an initiative that has support from different groups, including the WHO, Gavi, and CEPI, which is really a group that is looking at emerging infections and that could be prevented from vaccines. And this assures, if you will, equitable distribution of the vaccines for COVID-19 once they would be available. So these are all the countries that participate in that. And with that in mind, you know, there are many potential scenarios about how the vaccine could be distributed. But I do want to point out that, at least this is from the NAM in the US, you see that children, unless they have underlying conditions, they're not going to be in phase 1, 2. They will be later on. So we are talking about next year at the earliest, even to have some data on children. And similarly, pregnant women are not specifically listed here, but I do want to bring up, maybe for discussion again, the intersection between pregnant women who are healthcare providers themselves, and what do we do about that. So one last point, and that was mentioned also regarding the Argentina data. Once we roll out these vaccines, and even in the context of flu, critical to have vaccine safety surveillance systems. And these are some of the examples that we have available in the US. A few years ago, I looked up for what is available in the world, and this is one document that came out, just basically showing that most surveillance systems are passive, not necessarily moms and babies are included, and that there's big variability throughout the world. But surveillance systems for disease and for vaccine safety are critical as well for vaccine implementation. And I think I will stop there and leave it some room open for questions, I hope. Thank you so much.
Thank you so much, Flor. That was great. Very comprehensive, and it was just terrific. I want to thank our 3 presenters for this morning. We're a little bit behind schedule, and so I apologize that we really don't have time for questions. But I think the work working group, if you put in the chat your questions, at least the working group will have a chance to discuss those questions and what you bring up. I just want to take this opportunity to thank all of our presenters for what I thought was a very informative and great meeting. Again, thank Mary and Olivia for their organizational ability, our John Andrus, who really was the, and I'll turn it over now for the wrap up to John.
Thank you, Steve. I don't have anything else to add. I think you captured everything in the time we have. I just want to shout out to the speakers today and every day. They've been outstanding. Today was a very nice way to wrap up the discussions of the week, and look forward to the closed meeting immediately after. So once again, thanks everybody.
You're welcome.
Thank you.
We'll go into our working
Thank
group
you.
session now, and thank you everyone again.